Welcome to the Sustainable Clinical Medicine podcast. I am your host, Sarah Smith. I am a practicing rural family physician and the charting coach. This is the podcast for physicians and advanced practice providers who are ready to step back from the busyness of their clinical day to share ideas, question everything, and redesign their clinical day. We are redesigning clinical medicine to create sustainable clinical days and create time for our lives outside of medicine. Join us for discussions with world experts who are helping design sustainable models of clinical medicine and the physicians or clinicians who have discovered or designed sustainable models of clinical medicine for themselves. Before we get started, I just wanted to remind those of you who are working on backlogs, just check in the www.chartingcoach.ca/backlog-buddies is the place you can come and do your backlog alongside fellow clinicians and physicians. So if you want to kind of hang out and have some ability to stay on task for the 2-hour sessions, come along. We'd love to see you there. Good morning, everybody. Welcome back. So today I have with us guest coach and physician, now retired, Dr. Nancy Merrow. Welcome. I'm going to get you to introduce yourself to us.
Thank you so much, Sarah. I've really been looking forward to this conversation. And thank you for mentioning that I'm retired. It adds that end-to-end almost conversation we can have about how I discovered various ways to stay in the profession, be in the profession, thrive in the profession over an extended period of time, and come to the end of it with a sunset career that is as fulfilling for me personally as my practice was over the years. So who am I? I am a family physician by training. I have been Ontario, Canada based my entire career. And I am very experienced in medical leadership. So I would say somewhat early on in my career, I started to take that path in addition to practicing. And we can talk about how that feeds sustainability in the practice too. For the last for the last 20, I have 20 years of cumulative experience as the chief of staff in hospitals. And that has, of course, taught me a lot about the struggles that physicians have who are maintaining a connection with hospital practice in spite of all the chaos that reigns in the healthcare system. And I don't know where in the world you could possibly be where there isn't chaos reigning at times in the hospital sector. And I've been at the heart of that for many, many years. In addition to my family medicine training, which was done in Toronto, Ontario, Canada, I took a palliative focus for almost 10 years and delved quite deeply into not just palliative care, but end-of-life care, hospice care, and building sustainable systems for that. And I would love to talk a little bit about that for people who are looking around, seeing that things don't work very well and wanting to change that. More recently, in the last 2 years, I have been out of the hospital administration role and out of clinical practice, but working as a professional physician executive coach. I did some formal training in executive coaching at Royal Roads University in British Columbia, Canada in 2014. And over the last 10 years, I've been gradually building up a practice in that regard. And we can talk more about how coaching fits into the vitality that you can restore to your profession and your life when you're in that place of questioning, where am I going? How am I going to get there? So, family physician, daughter of a family physician. Mm-hmm. My dad was in family medicine my whole life, of course. He had a long 40-year career in rural family medicine. And that was one of the original inspirations for me to pursue the career. Married for 40 plus years, 2 grown children, two young grandchildren. So I'm starting to relive some of, wow, I wish I'd known that when I was a parent. that would have really worked for me, but it's new knowledge. And watching my kids become parents and how the world has shifted to teach us much earlier on how to build resilience and mental health and, you know, keep people moving in positive directions as they learn and grow. So I think those are the core elements of what makes up Nancy Merrow at this time. My passion now is in using coaching to nourish physicians and really help them discover what they want and how to get it. It's extremely powerful.
Yeah, yeah. So let's take you back. What was it about Dad's career? Because I'm always curious about, hey, there's a physician and whose kid wanted to do this too. Why? What were you noticing about kind of Dad and his career as you were growing up? Obviously, it didn't have a completely negative impact on you.
Yes, quite the opposite. I mean, there were things, and I think we could get some of those on the table early in the conversation. My my dad was a family physician of the breed who never shut the practice off.
Mhm,
There are still people like that, I think, but in those days it was the norm, not the exception to
mhm,
always have. I mean, there were not even any pagers where we lived and he practiced. There was a buzzer on the front door of our home, which
mhm.
encased his office as well. And that buzzer rang in his bedroom. So people could come to the door any time of the day or night and he would be woken. And another thing I remember about my dad was he always kept clothes hung on a hook so that he could get dressed quickly and get out the door without disturbing anybody, turning any lights on. And, you know, so we grew up in a small town. He was one of two family physicians when he started the practice there. He was extremely well respected, as physicians were and are in their communities when they're intimately known by their communities. And I think that's something we should touch on later in the conversation, is about how that community connection helps to sustain physicians in the demanding roles that they hold. And so the physicians, they did everything. I mean, my dad was a coroner. He had hospital privileges, even though the hospital was 45 minutes away.
Mm,
He went there at least 3 or 4 times a week. He always went there when he had patients. And as we were growing up, the girls in my family, of which there were three, each took our turns actually working in the practice as a secretary and helping with the billings and learning the back office things about how the practice worked, calling the repeats into the pharmacy, getting to know when the police were calling, we had to interrupt what was going on because it was a coroner's call. I mean, those things that make medicine so interesting and exciting really caught hold of me early on. The status, I won't deny it. And I think most of us have some attraction to the status that physicians hold in their communities. The the excitement of that buzzer on the front door ringing, and I'll never forget some instances which there would still be people alive now who would know what they were, but it it wasn't uncommon for people with life-threatening injuries to ring that buzzer because there wasn't even such thing as 911. I mean, there was still a 7-digit phone number to call the ambulance,
mhm.
and the phones were dial up, ring, ring, 7 digits to get the ambulance. I mean, these are things that the physicians overcame by just being available. I wouldn't recommend any of that for anybody now. at all.
That's what I was just thinking in my head. I don't think I would recommend a doorbell.
That
Nowadays,
rings in your bedroom? I know, it's
I'm a
hilarious.
country
Although,
town. My
Sarah,
my community know me well,
I,
and
I
I could not guarantee that they wouldn't ring the doorbell at 2 in the morning just because they could.
absolutely right. And I would just underscore that point by saying, if your listeners have got their cell phone in their bedroom when they're not on call, wake up. Maybe a little step there you could take. You know, cut the wires on that doorbell when you're not on call. So, one thing that stands out very, very vividly in my mind that I think I can share because there would be no one left alive who would remember it is my dad took me on some coroner's calls when I was quite young. I would be a teenager, young teenager. And like I was totally jazzed by the excitement of that. You know, the police are there, the firemen are just leaving, the whole 911 thing has happened, the failed rescue effort or whatever it was. And then sorting out what happened and who was there. And so I found that thrilling. And I think there are a lot of things about medical practice when you're introduced to it very young that are quite thrilling before you understand that there's such thing as bureaucracy, you know, or paperwork or
Mhm.
these there's that thrilling aspect to various parts. We used to go to the hospital on rounds with my dad. Back then you were still allowed to take your children to the hospital. It's crazy when you think of it now. And I had instances later when I became a chief of staff when I had to curb that practice of bringing the kid because then we suddenly understood about infection control and like, oh my God, you can't be doing this, you know? Yes, it's adorable, but no. And but we were comfortable in the hospital environment, you know. We would hang out in the lobby with some dimes for the vending machines, and the switchboard operator would keep an eye on us until he was done seeing his patients. So all those things made, for me anyway, not for my siblings. I'm the only one who got hooked early on and pursued it. And then, of course, as I got farther along, learning biology and physiology and pharmacy and those sorts of things played to my strengths. You know, I wasn't drawn to the arts as much as I was drawn to pure science and how that, you know, the human body and how everything we can do in medicine can impact that. So I came from all those roots and attended my father's alma mater, University of Toronto, and came back to practice at the hospital where he had been in his career all that time. I never went back to the rural setting, though.
Mhm.
I didn't, I mean, I had other ambitions. You know, I wanted to be a mother. I was married by that time and I had in mind family life. And already my generation looked at family life commitments much differently than he ever did. Plus, there's the gender difference of me being, you know, the physician and the woman, the wife, the mother,
Mhm.
and doing all that during the 80s and 90s was very, very different than committing your life with a doorbell in the bedroom, you know, to whoever wants to knock the door. Um, in Family medicine definitely drew me. I knew it was the way to have the most breadth.
Mhm.
In my view, it has the most breadth and can have the most depth depending on how you want to pursue it.
Mhm.
I just found that continuity of contact with my patients over time was, again, a sustaining factor for me, knowing that there was a thread we were following and we weren't going to drop that thread or multiple threads, as the case may be. So I went into family medicine and I spent my first year of practice doing locums all over the place to see how to do and not do certain things. And I'll tell you how certain things you learn not to do. I worked in an office one time where after allergy shots were done, we threw the syringes in the garbage, in a garbage bag. Like there were no sharps container in the physician's office. Oh no, that's for the OR. We don't worry about that. I think we do. And things grew. So I've seen a lot of change in the demands on family medicine from the I do what I want, I do what I think is right, to now quality standards and reasons why there's so much more due process, and you could call it bureaucracy, but oversight, of how we do things, whether you're in the office or the hospital or somebody else's clinic. So I set up my own practice and I thought I knew how to do that. I did. I had some pretty good mentors and I was well trained. And I had my own practice for a couple of years before I had my first child. And then I invited a locum into my practice, which, believe it or not, was as easy then as calling the OMA locum service. And guess what? There'd be people available and they would come. Who knew? I mean, it could be that simple. And that has gone way by the board for people as well. But you could be in solo practice back then because you could get a locum when you needed one. Um, anyway, that locum ended up staying with me in the practice, and we traded off mat leaves for 10 years. I had one, she had one, I had another one, and she had another one. And we went on like that, very happily practicing. And we added a third associate, and eventually we were a 4-physician practice, which was fantastically sustainable at that point. And somewhere during that time, when my kids were getting to be more mid-school age, I got the itch to be in leadership, and I ran to be the chief of, I was on a few committees, which again, I would suggest to your listeners, if you're not involved at any level in any of the ecosystem of medicine that you're embroiled in, get involved. Yes, it's something else to think about. Yes, it's more. But there's a sustaining energy that can come from knowing people are working on these issues. This is what they're doing, and you can help. And it will make a difference over time. And I learned that in so many ways over the years, starting with the hospital that I was practicing at, and I was critically devoted to family birthing care at that time. My residency was at Women's College Hospital in Toronto, and I was trained in birthing practices that were innovative at the time. I mean, imagine the length of stay being cut down, Sarah, to 3 days. We're cutting this right down. 3 days, that's it. It's enough. Imagine that now when women are going home same day.
Yeah.
But it was huge. It was huge.
Yeah.
And I came to practice where people were still being kept in the hospital for 7 days. And, chaos at home with the other kids and the mother-in-law and the dad trying to hold it all together and get back and forth to the hospital and be whatever he's supposed to be trying to be to his wife. And so, I forget what we called the committee, but it was something about updating maternity practices. And I got involved really early on because I brought a different experience that when I said, well, yeah, we do this and it's safe and it's being done and we can try it. So committee work, and it leads to, being the chair of something, task force, work group, whatever. And that leads to being the chief of the department eventually, and on the medical staff, association, executive, and then finally chief of staff, so over about a 10-year period, I moved through various levels of leadership, which again, I just would find things that were extremely trying about the family medicine environment. And I don't know if this is a good thing or a bad thing to tell your listeners, but the problems have not changed. They're amplified. They may be a bit more intense in certain ways, but the things we were working on throughout my entire career still need to be worked on because family medicine is extremely challenging. It always has been.
This makes
From my
sense.
perspective, it was never
Well,
simple.
what were you working on? Because I'm curious. You had solo practice for 2 years before kids, but still, what was life like then for you as a family physician, solopreneur, solo practitioner, family medicine, rural country, but not rural? You said you
Yeah.
had made a choice there to be a little less rural.
Mm-hmm.
Yeah, tell us what were the challenges? What are you still seeing now that you were seeing then?
One of the speaking, I'll get to the challenges in a
Mhm.
moment. I do want to give due credit to the group that was in family medicine when I started my first practice. They did have what we called town call. And at that time, there were about 20 family physicians who were on the town call roster. We had an answering service, actual person answering the phone who 24/7 who had the call system, and we would each run a clinic out of our office when we were on town call. We didn't have a centralized after hours place in the early years, but for those 2 years I was able to sign out in the evenings and on the weekends for my general practice issues. I was doing my own birthing care, and that at the time was very much your patients in labor, you come unless you're out of province, like you come. And we did our own births. So when I had children, of course, that was just no longer going to be a given that I could pick up and go whenever I needed to. And at that time, there were 10 of us doing our own obstetrics at the primary care level at the hospital where I was. And through a series of meetings and pilots and, you know, wrenching from the grasp responsibilities for birthing for people who'd been so dedicated. And I was practicing with people then who'd already been in practice for 20 or 30 years. Oh, to not come in for my own patient. Oh my goodness. It was sacrilege to think you wouldn't at least try to get there. But there was a whole cohort of young mothers like myself who agreed we had to do this. If you want to come in for your own birth, great. But if you can't make it, there's somebody on the call roster and they have made arrangements and will be available. And so when we were on call, we had to make sure either the partner wasn't out of town or grandma was coming or the neighbor could sleep on the couch, whatever. A lot of different arrangements to make sure we could do call, but we finally got a 10-person call rota for GPOB, which kept a lot of us, I think, in that arm of our practices for the childbearing years when a lot of people in the past had to give it up.
Mhm.
So that was huge. The town call was it was very effective in many ways. It was much more effective when we agreed to have a central location that people could know where to go. You know, calling the doctor on call, getting the name and the address from the switchboard operator, finding your way to some office where you've never been. It was it was good at the time. It was better than everybody doing their own call. But two of the physicians in our community decided in an entrepreneurial fashion they would set up a proper after hours clinic.
Mhm.
And we all had our share of shifts, and they were only 4-hour shifts. There were enough of us to cover it with only a 4-hour shift, quite doable. And we were open 7 days a week until about 8 o'clock at night. And that kept us going. Like the rest of the time that I was in family medicine, that sort of arrangement, a call schedule for your GPOB. Hopefully, people who are still doing inpatient care have got some kind of arrangement with their colleagues to handle admissions when they're not immediately available. And you have to work those groups, they don't stay together by magic.
Mhm.
They need to know what their purpose is, and there needs to be some leadership at some level. And this is where I was always inspired to get people together and talk about what was working and not working and strike a work team and do whatever, update the forms or the
Mm,
schedule or the payment model. There's always this kind of back office work that
mm,
needs to be done. And if physicians do it, or at least oversee it, it turns out much better than if there's just an office manager who's not getting all the input that are necessary to make it work for the physicians. So that's the sort of thing I'm talking about when I say there had to be things put in place that weren't in place, and that the small group of us that decided to take a leadership attitude towards this and progress made things happen. And doctors have always had that power. They've always had that power. It's coming to that level of acceptance that you have to do it. Nobody's coming along, Sarah, to save us. And this is something that I love about the work you are doing, which is helping people winnow out the things that are directly within their control and helping them see ways that others have overcome or enhanced or eliminated those things, right? I mean, this is absolutely vital for family doctors right now because we have been put upon, we have been overworked, we have been the recipient of downloading of tasks and practices, and that has to shift. But like everything, it shifts with shifting yourself
mm.
and what you say to people and what you do and how you approach your practice.
Yeah. So I'm curious, when you had these young mums who were doing obs and you had these not mums who were doing obs and have been doing it for 25 years and come in for every patient of their own who's in labor, and you start to have these conversations around, hey, wouldn't it be nice to be able to leave town knowing that we got your back, we're going to cover your obstetric patients for you that week.
Mm-hmm.
And then you made a mention of, if your patient's in labor, you can come in if you want to, but know that there is somebody on call. And the mental change required, because you can totally understand some of the people within that call group, at least maybe initially, would have come in for every one of their own patients, even though there's somebody on call.
Mm-hmm.
And it's driven by multiple factors. It's driven by, well, they're my patient, I will go. Or it's driven by, I must. Or it's driven by, of course, I'll be there for you, my darling patient who I love so much, because, I will sacrifice of myself so that you will have, for sure, me delivering your baby. Right. So can you remember or understand the changes that were required to sort of start a new model and have that become an effective trusting of your colleagues and imparting to our patients that this is why this is better, even for you, the patient on the receiving end of having somebody else deliver your baby for you, right? Because that takes a
Mm-hmm.
lot of courage from the patients and from the physicians to do things differently.
Yes, it does. And taking the answer to that question to the leadership level,
Yeah.
I would say two things. Always start with a pilot
Mm-hmm.
project so that no one has to commit or permanently release their attachment to how they believe things should be.
Mm-hmm.
Let's just try it.
Mm-hmm.
And the other thing I would say is, to the best of your ability in any kind of leadership, whatever you're trying to get done, is try not to box physicians in. I think physician autonomy is our greatest strength and our greatest challenge to change management in whatever you're trying to achieve. Helping physicians, I'm going to use the word surrender, and it's going to make the hair on some people's necks stand up, Sarah, but
Oh, we
helping
talk about this a lot, so don't worry.
helping physicians surrender to the it will probably be okay,
Yes.
as there's no certainty. There's no certainty in any situation, most situations. But somehow, if we're there and we're holding whatever it is, the needle, the forceps, the whatever, we feel like it will turn out okay if we're there. So, we want that for our patients.
Mm-hmm.
And I don't want to make it sound like forming a team is simple and happy and everybody likes the way likes the way their colleagues do everything. I've worked on some teams that are that cohesive, but I don't think it's the norm. I think most teams are quite stormy and difficult, and it's just easier to do it yourself sometimes. And I think a lot of experienced physicians who resist getting into team-based or sharing care or whatever it is have found that over the years that, oh, before you know it, you're into some kind of politics because, you know, this one likes Prostin gel and this one goes straight to the tablets and this other one doesn't like the PIT protocol. So they've got their own little tweaks and the nurses have always known that. So this is how they do it. And it's like, okay, moving towards standardization is part of that. And it's been very challenging. And that is physician autonomy.
Mm.
And surrendering some of your autonomy to the greater good and the sustainability of the practice, and coming to terms with the fact that your own sustainability is on the line as well. So if you can get to what the needs are of the others that you're trying to bring along, it's the old interest-based negotiation. Don't take a position, figure out what everyone's interests are and how you can make a quilt out of it where all the patches, are sewn on, and everybody likes the final design or at least can live with it.
Mm-hmm.
There's no magic to this stuff. It's hard
Mm-hmm.
work. But the people in my group that were young moms were of a like mind. I mean, we just had to have some kind of support or we had to quit OB. That's all there was to it. You can't be running out in the middle of the night, period, full stop, unless you've got a plan.
Mm-hmm.
There was another cohort, though, who were pilots and wanted to go flying. It was their hobby.
Mm-hmm.
And there were others who had other, or they had a boat and they
Mm-hmm.
and they wanted to be out sailing. So they're way past the childbearing years. They don't want to hear, oh, get your mother to come and stay with you. It's no big deal. But if you want to be up in the air, you ain't coming down in 10 minutes and showing up at the birthing suite. If you want to be out in the middle of the lake
Mm-hmm.
on your boat, you ain't coming back either. So, and yet they were trying to,
Mm.
I'm on my way, I'm on my way, I'm on my way. Well, no, we need you here.
Yeah.
So there's common interests, maybe not on the same specific thing. So always looking behind what people are saying, just a little deeper and doing that listening about what really matters to them. And then looking for ways to just put something in place, try it, tweak it, make it better. Um, there's never, I don't think, been any better way to do change management. I think it's been the same
Yeah.
always.
Yeah.
Find out what people need, find out what their interests are, clearly define the problem you're trying to solve,
Mm-hmm.
and then just try stuff and see what sticks.
Yeah. Try it, evaluate it, come back to it,
And
see what's
don't
working, what's
box
not.
any don't
Yeah.
box anybody in. Don't box anybody in. I think the evolution to full sign out call in that group took more than 5 years before the last person who was hanging on to, I always want to be at my own births, discovered the joy of going sailing without their pager.
Mm. Yeah. It's fascinating. Any insights into what might have been the obstacle there? Like the final kind of like butting up against, I don't want to give this to you team.
Dare I say ego?
Mm-hmm.
Dare I say that, at least in my experience, there are some physicians whose identity is so intensely wrapped up in how they work, not just the fact that they're a doctor, but how they work. And so that's why I use the word surrender. To them, it's like they have to give up something that's intensely important
Mm-hmm.
to how they feel about themselves. I think if we reflect on that, it's true of a lot of things we don't like to examine about why we are physicians, what it feeds in us to have that much power, prestige, and responsibility, and what surrendering some of that threatens us with. I read a great book, Sarah, years and years ago called Medical Narcissism.
Mm-hmm.
Do you know this book?
I have not read it.
You're nodding because, it's always kind of juicy to start talking about narcissism and the role that it plays. The tone of the book was not about difficult behaviors or challenging relationships. It was about this narcissism that we hold about, if I'm there and I'm doing my best, everything will turn out okay. And then when things don't turn out okay, which inevitably for all of us someday they don't, or they do, whichever,
Mm-hmm.
uh, the narcissistic threat to your image of yourself as a caring physician, a careful physician,
Mm-hmm.
is mortally wounded when you have an outcome that, in spite of everything you did or did not do, has harmed a patient of yours that you care about very deeply. So, protecting ourselves from those kind of experiences is a driver that I think causes a lot of people to just stay in a practice model where up till now nothing terrible's happened. So I think I'm on the right track and I'm just going to keep doing this.
Yeah. Yeah.
I hope that resonates with a few people, that there's a terrible wound that occurs when you are part of an adverse outcome in spite of being the best doctor you've always wanted and tried to be.
Mm.
So we
Yeah.
do a lot to build a shell around ourselves to reduce the chances of that happening.
Mm. Yeah. Okay. And just seeing how that can impact you when you're trying to work with others or create a sustainable practice for yourself, and how that can show up
The
to
change,
threaten the shell of
the
safety.
change is a threat. That, thank you. Threatening to crack that shell and learning over time, which is the only way I think to learn, unless you've really got some solid senior mentors who will be honest with you about things that have befallen them during their
Mm.
career. And again, medical narcissism uh, prevents us from talking openly about these things sometimes. It's very difficult,
Mm.
for
Yeah.
most people. Yeah, I think I'll just pause there.
Mm.
There's a lot in that.
Yeah, agree. I like that there's other ways of doing things that we can be exposed to, have talk about, be part of change. We were talking right before we kind of jumped onto the call to say, in our hospital, with our new EMR system, where rural doctors working clinic, working hospital, working in emergency department, working in inpatients, and the requirements of the computer system are making it longer to do the work at the hospital, so that now there's this spreading of the shift call will go longer because the encompassed work required. And then it follows you into the clinic. It dings in your pocket all the time because people will send you messages from the EMR and saying to ourselves as a group, because we've been working together for a long time, saying, okay, time for a rethink, a redesign, a remodel, just the possibility of change. Guys, what do we want to do here with our emerge shifts, with our inpatients? Do we want to start to design a different way of doing this so that it may not look like I see the patient, I admit the patient, I look after the patient, see the patient every day, I hand off on the weekends, we have that, and then I come back on Monday and I see the patients and I go to the clinic, then I come, all these pieces, we're segmenting ourselves, or do we change it up? And just allowing ourselves to say, let's talk about what change up could look like, and starting the process of that. Think again.
We have a variety of practice models where I recently retired from. We have full-time hospitalists who do only hospital work. We have family physicians who do all their own hospital work, sort of from 0700 to 1700, and then they sign. So we have that model. And we also have a model where the group has decided they will be the group's hospitalist for 7 days. And they are, I wouldn't say exempt from office work, but everybody knows whoever's turn it is to be at the hospital is going to be less present in the clinic. And although they might get through their results, they might not get through all their messages. And yes, there's going to be more of their patients in the after hours clinic. And there's just some forbearance required by the members of the group. That has potential depending on the group. It's got to be a number where the number of admits is going to be manageable. I mean, you can't have one hospitalist for 20 family docs who are all, going to stay in the office that week, and one guy is going to scramble around, try to do it all. But there's probably some math you could do there, Sarah, to figure that out, right? And it's that acceptance of, what goes on at the hospital now is more challenging, more chaotic. The patients are patients more complex these days? I doubt patients themselves are more complex, but the environment that you have to navigate them through to manage all the threads is definitely more complex. Yeah. And so it's okay to say, you know what? Hospital work is enough in a day. Let me do it. Let me do it well. You guys guard the farm. Yep. And forgive me. And when you're at the hospital, I will do the same for you. To me, in all the models that I've seen work over the years or not work, I think that has the most potential to keep physicians in hospital work. Is you've got to figure out how to share what goes on at the office. But this is another thing. Oh, I can only see Dr. Smith. She's the only one that understands me. I've got to have the next available appointment with Dr. Smith. Be that as it may, your situation sounds urgent and Dr. Jones is here, and I would encourage you to go. It's the staff have to kind of overcome. So the patients have got to overcome it, staff got to overcome it. None of this would be any surprise to your members who are trying to keep all the four horsemen of family medicine trotting along, the office, the hospital, the birthing suite, and the after hours clinic. Never mind the call. And I see we're going to run out of time, Sarah, but we didn't talk about sort of palliative medicine and how to get that organized, but the principles were the same. Yes, of course, I want to be there when the death occurs and come and do the pronouncement and help the family through that last day after we've been, working so diligently to make it the best memory that we can for people. But same principle. At some point, I am going to be either out on my boat or up in my plane or at my child's graduation, and somebody else is going to have to come. So how do you build in team norms? And that is a term I would like your group to think about. can we come up with our desiderata? What are our team norms? What are the things we value that we will uphold no matter who's on duty, who's on call, who's all that? If you can come to some sort of very high level agreement about what really matters to the patient care that you're providing, that everybody will agree, we will endeavor to always do this. We will endeavor to never do that.
Mm-hmm.
There are things, that start to build what the team stands for. And that's something else I would invite people to do, is inspire the group with, what do we stand for as a group? We're the South Shore, Bayside, whatever, clinic, team,
Mm-hmm.
whoever we are. What does that mean?
Mm.
If you're fortunate enough to be a patient of this group, what does it mean that we're
Mm.
going to deliver for you? What do we deliver for each other? But Sarah, this is all stuff, and I don't want to lose a minute to say how coaching can help individuals, teams, groups move their wishes and thoughts into concrete goals and
Mm-hmm.
move those goals into action. And this is the challenge, I think, for family doctors right now, is we all want things to change. We all wish things would be better. We all have ideas. Turning those ideas into goals that are, the old term, specific, measurable,
Mm-hmm.
achievable, you know, relevant and time bound, and then moving them forward. This is what coaching does.
Mm-hmm.
Clarify the goals, keep things moving forward. And that's how I came to coaching. I was thinking about a big career change, and I worked with a coach for 3 months.
Mm-hmm.
We reflected on my values. We reflected on my priorities. I was forced to admit my narcissism and how that was playing out in the prestige that I was seeking and what I needed, and looking at how I was the author of the things that needed to change, and then
Mm.
starting to change them one by one. But the coaching, your coach will call you out on your BS and say, no, 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 no. I've heard this before from you and it doesn't resonate in what you're doing. So quit saying it and not doing it. You need people in your life sometimes who will do that for you. And
Can
it
you give
can't
us an
always
example?
be the people at home. It can't always be the people at home. At some point, they don't want to hear it anymore. Are you
Yeah.
doing it or not? Come on, enough.
What's an example of that as you move through those 3 months from clinician to retiring, or whenever you used your coach? An example of kind of a goal that you worked through with that in that specific time frame, or just to help us understand that a little bit more.
Perhaps a goal that would resonate with a lot of people on the call right now would be how to sustain and enhance the relationships that I wanted to not just survive the change, but be better.
Mm-hmm.
If I make this big change,
Mm-hmm.
how will my life be different? And I think that's a really important question. You have to sit back and say, how will my life be different? Will I be more present at home or less? Will
Mm-hmm.
I be, more distracted or less? Will I be uh, have more status or less? And going through a values exercise, and there are numerous things a coach can do with you. One called the wheel of life, where you've got this picture of a wheel, and you're nodding like you may have heard of this, but there's family, money,
Mm-hmm.
fitness, da 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 da, all around the wheel. And if there's deficits, huge deficits, the wheel is extremely bumpy when you draw the picture, and smoothing that out becomes a source of the goal. And for me at that time, I was thinking about moving from a large regional center where I was the chief of staff to a medium-sized place where I would perhaps have, I don't know, I'm not sure if it was less status, but it wasn't the kind of career move people expected of me at the
Mm-hmm.
time.
Mm-hmm.
and and yet for me it got me a healthier lifestyle,
Mm-hmm.
a more positive outlook on what the retirement years for my husband and myself would look like, more time to be a grandma. And I gained so much from making that move. But until I sat with my values, my attachment to my status and money and different things, and unpacked some of those things with the coach, I was just spinning around,
Mm-hmm.
spinning around in my own head. Should I, shouldn't I, could I, would I?
Yeah.
And I think as physicians, you can apply it to anyone, but my passion is about helping physicians settle into what they really need to be connected to make these big decisions, or
Mm.
just to feel more comfortable with what they are currently doing.
Yeah.
And that's that. And after working with that coach, I mean, I made up my mind. I'm becoming a coach. That's it. Like, I had never heard of coaching before this, Sarah.
Mm-hmm.
And here I was, like every 2 weeks. So, Nancy, you said you were going to do this. How are you coming along? Oh, well, I didn't. Okay, what's in your way? Not judgment, like, well, you said you were going to do it and you should have done it. No, it was like,
Mm-hmm.
something's in your way. What is it? Let's
Mm.
let's dig at that. What stopped you? Where did you go zig instead of zag? I found that extremely powerful. Because you're a physician, people expect you to know, they expect you to be able to figure things out. They expect you've got a direction and you're following it. It's not fair to assume that you've got everything you need to navigate every circumstance that requires
Mm.
progress and big decisions. And it's
Yeah.
okay to build that personal board of directors around you, your mentor, your coach, your partner in life, your friends, um, your staff. There's this whole ecosystem within which you are functioning,
Mm.
but you're still only in control of the parts that you own.
Yeah. Yeah.
So learning how to leverage those and take your power.
Mm.
It's
Even
amazing.
even if you're staying exactly where you want, where you are, even if you're not moving location or job or career, even just saying this isn't working for me and why not? And what could I be do see change that could create a more sustainable where I am right now? Like this is also part of that sustainability quest is the power of an outside perspective,
Yeah.
the power of creating goals for yourself. What do I actually want? Because we sometimes don't even step back and say, what do we want? You know what you're not enjoying, you can say that out loud. You say it multiple times. You're like, I don't like this. I'm so frustrated by this, blah, blah, blah. But not saying, well, what is it that I'm looking for? What am I wanting? And how do I go create that? I think that it's possible. Even
We couldn't end the conversation on a better note, Sarah. I mean, this is why you've been drawn to the work that you are doing.
yeah.
This is why I've been drawn to the work that I am doing. The, the most challenging coaching question of all is, what do I want?
Mm, yeah.
And I would encourage people to sit with that. And if you can't get there, some coaching may help you clarify it.
Mm,
Yeah.
yeah.
The
Yeah.
coach will pull out what is inside you that needs to be reflected upon to get you where you need to go.
Mm-hmm. Yeah. So good, Nancy. How do people find you, Nancy?
Oh, I am at mdchoicecoaching.com,
Mm-hmm.
and I'm on LinkedIn under my own name, Nancy Merrow, and
Mm-hmm.
happy to have contacts through either one of those things. I am not at the moment on Instagram or
Mm-hmm.
TikTok, and I'm afraid I lost my love of X and stopped tweeting a while ago. My work is one-on-one
Mm-hmm.
with people who connect with me because they've heard of me, or someone they know and trust knows and trusts me. And now that you're in that circle, Sarah, I hope some of your clients will find me. And we're both members of the Canadian Physician Coaches Network, which is a great place for people to find out more about coaching before they dip their toe in.
Mm-hmm.
So that website has got some great tips for how to find a coach, how to choose a coach, how to work with a coach. And we are building it all all the time. And before we sign off, it's funny, I wrote down the evidence base for coaching. I'm a physician, I always have been, and never would be involved in something that doesn't have some evidence base to support it when challenged. And that's very dear to my heart. And there's a beautiful study in JAMA, August 5th, 2019, they did a randomized trial with 88 physicians. 40 something got coaching, just 6 sessions, and 40 something went on with their lives as, but they measured their well-being, their work-life satisfaction, their symptoms of burnout, their resilience. Very, very nicely done study that showed, and there have been more since then. And on my website, there are a few links to the building evidence base where physicians can feel comfortable. This is real. It's real. Coaching conversations cause a shift for people that gives them back some of what they have been spending too much of in the wrong direction. Their resilience, their well-being, their and the symptoms of burnout, which are so pervasive. And it was done in 2019 before COVID. Like, we knew then and have known for a long time, Sarah. It's not that we've all been knocked on our keisters by COVID, which of course we were, but we're popping back up now. And guess what? The problems in the system are still there. And the work that you are doing and the work that the coaches in our network are doing is a piece of what is accessible to physicians to reach out for.
Yeah. Yep. Adding a tool to your toolbox of how to feel better, how to make changes. So thank you so much for this conversation. Anything else, Nancy, we didn't talk about that you wanted to talk about before we close up today?
Thank you for the work that you're doing. I have picked up so many pearls from the conversations you have with your guests, and I hope people enjoy following you and that you keep it up, Sarah. I mean, it's all on top of everything else you are doing. So here's you, doing exactly what I said. Find that purpose, find that thing that fills your cup that is making a difference over and above what you're doing for your patients every day. Because, the doctors in the end will save ourselves and each other. I believe that.
Yeah. Thank you so much. Have a good day, everybody.
It's been wonderful. Thank you so much.
Bye. Thank you for being part of the Sustainable Clinical Medicine podcast. If you'd like to learn more or join us to help you get home with today's work done, go to chartingcoach.ca. There you'll find all the information on the Premier Lifetime Access Charting Champions program that is helping physicians get home with today's work done, with all the proven tools, support, and community you need to create time for your life outside of medicine. We would love to see you there. Until next time, thanks for listening.